Good morning. My name's Dr. Emery Jaffe. This is the title, Game Changing. This is the Topcon ALADDIN 3.0 discussion. This is my title. Let's see what this has done for my practice over the last year and a half. We purchased the first two ALADDIN 3s in the United States over 18 months ago. Before the Topcon ALADDIN, we used 3 different devices to measure corneal power: the AAO Master 500, manual keratometry, and topography for selected cases. If the measurements varied widely, we would use lubrication or restasis in an attempt to improve the readings. This was optimization at that time. When there were still some differences in the corneal measurements, we had to resort to the 2 of 3 closest measurements, or the 2 of 3 rule. This didn't give us great confidence. The great amount of time was also required to repeat the measurements on 3 devices. Manual entry of the measurements into the IOL formulas was another problem. We would have a second individual check the measurements. Only premium lens patients got optimized. We did not have the time to get topography readings on everyone. Many delays occurred if a patient decided to change the lens power in the middle of the process and upgrade their lens. This kept us very busy, and this was before we ever used EMR. This is it. The ALADDIN 3.0 uses 26 placido rings and 8 infrared LEDs to measure keratometry values. They are quite accurate. This is a huge benefit in seeing the topography and the corneal wavefront measurements in every patient that gets measured. Technicians enjoy the speed of the ALADDIN. We encourage them to measure early in the workup. Follow-up exams clearly demonstrate changes with treatment. Over time, we could look at the topography and quickly decide what needed to be done. Also, there are no manual entries. The latest Barrett suite and the Olsen formulas are used to calculate the IOL powers, add fast acquisition time and reliability, and you have the current standard for a busy refractive cataract practice. This is a patient scan by our last topography device. Everything looked pretty good. It's a little lower resolution, but I was happy, I thought. This is the same patient with the ALADDIN scan. Notice the details that were not present on the last scans. The apex readings right here and here are over 4 diopters apart. The arrow in the left eye shows up here, shows an area where the topography has a steep power change in a small area. This is always abnormal. This patient had epithelial basement membrane disease on slit lamp exam. Now let's look in more detail. The measurement summary up here has the axial length, the Ks, the anterior chamber depth, the lens thickness, the white to white, and the central corneal thickness. Ketorefractive indices below detail the keratometry readings at 3, 5, and if you want 7 millimeters, and more details about the scan. The apex keratometry readings are much more useful than just the, and the apex is over there and there, than just keratoconus detection. And these used to be used just, a lot of times for keratoconus detection, but they're really useful. Wavefront data is at the bottom, extremely useful. That's down here, all the wavefront data. On the right side of the slide, the cataract measurements are over the IOL powers for the lenses that you use most often. Now let's put all this to work. When the corneal surface is very unstable or a patient blinks during the scan, the ALADDIN will warn you not to trust these measurements, displayed with a caution sign at the top. See the arrow? A slightly better scan of the same patient is seen on the right side of this slide. This is a patient with dry eye, right eye, and you can see that the topography is not looking so clean. Optimization reduced the aberrations map in half, while the against the rule of astigmatism became better defined. These numbers, getting so much better, gives you confidence that you can trust the measurements that you're looking at. Even though these topographies don't look perfect, they're so much better, and there's only so much time sometimes for some patients to optimize them, that I can trust this now because I see the measurements get better and the wavefront abnormalities get better. These patients have something else. The corneal surface is very unstable. These patients have the typical crab claw appearance of topography. The astigmatism is very high, and the apex readings are off the chart over here and here, and the wavefront data is really bad. When you see this, and the ALADDIN shows you all this data, you can't trust all this material, and you can't put a multifocal in a patient like this because they're just not going to do well. Maybe if you, in a patient like this where the numbers aren't quite as bad on the right, you might be able to put a toric lens and do well. This patient was sent to me by a refractive surgeon for cataract surgery, and she had had LASIK twice in the left eye 2 years before. The aberrations map were off the chart. If you look, this number is over 10, and 5.78 of comma is way abnormal. Her corneas actually looked unclear, and the cataracts were really mild. So I'm not doing cataract surgery on this patient, and I have to tell her that basically her cornea is the problem. This is a myopic LASIK. We see much lower levels of distortion, and a patient like this, I would personally do a multifocal in, or at least a expanded range of focus lens, and I think, you know, this is much better. Both of these eyes had high astigmatism, seen here. Really high apex keratometry values there and there, and moderate distortion in both eyes. Both of these patients had had RK previously, and these eyes you have to be careful with. So that's my front yard. I love plants. Using high-resolution topographic data and corneal wavefront analysis results in stronger screening for corneal disorders that will affect your outcomes. Greater refractive outcomes are more easily achieved with the ALADDIN. You have a choice. You can optimize and impress, or treat postoperatively and try to explain what went wrong. Thank you.